All right, well, good evening, everyone, and welcome to another edition of the Community Connections, sponsored by the American Lung Association. My name is Tim Morris, and I am the chair of what's called the Mission Committee at the Lung Association. And our group was founded in order to try to help the Lung Association decide about important ways to complete its mission to serve the health needs of the San Diego community at large. Part of that is the creation of this Community Connections series, and we hope you enjoy it. Before we get started, I do want to give a plug for a really fabulous event that this will be this second annual Champions Unite evening that will be on June 16th at 6 p.m. It's a really fun time. It is a fun event of a lot of popular local athletes who are doing various talent shows and interviews, etc. It's a wonderful fundraiser for the Lung Association. I really do hope that you take advantage of the opportunity, register for the event, and watch. As I said, it's on June 16th at 6 p.m. There will be a link in the chat box if you'd like to pre-register. I think pre-registration is necessary in order to get a link to the actual event. And if you're not watching this live, you can either see the link right there on the screen, or it's champions-unite.org. So please take advantage of that and register for it, please. I would also like to thank the Burr Heart and Lung Clinic at Sharp-Grossmont Hospital, as well as the San Diego Foundation for the support for the Community Connections series. This, as I said, was the third series that we've done for the spring of 2022. These will also be available on YouTube. So if you're watching now and you see other topics that you're interested in looking at, they're all available on YouTube. We've heard about various different topics, including asthma management and environmental effects on lung health. We had a special session on culinary medicine, and recently had a really informative talk about the adverse effects of vaping and smoking, flavored tobacco, and synthetic tobacco. But this next coming week is the Turquoise Takeover Week, in which time we focus a lot on the risks of lung cancer, especially lung cancer in women. And so we thought we'd finish our series up with two back-to-back talks about lung cancer screening and detection. So we have Dr. Philippe Montgrain, who is a faculty member at the University of California, San Diego, and one of the lung experts in lung cancer at the San Diego Veterans Administration Medical Center. He's going to be talking with us about lung cancer screening. So Dr. Montgrain, welcome.
Thank you. Let me share my screen. Is now a good time?
Perfect.
Okay. All right. Hopefully you all can see that. Well, thank you very much, Dr. Morris and the American Lung Association for having me today on May the 4th. So may the 4th be with you all. It's a pleasure to be here to talk about a topic that's very important to me, and that's lung cancer in general, like Dr. Morris said. And lung cancer screening is a very important intervention that we have to really improve outcomes and save lives when it comes to lung cancer. And so it's my honor to sit around the dinner table and talk to you a little bit tonight about this topic. I am going to keep this very informal, and I'm looking forward to our panel discussion afterwards. I want to start by talking about screening in general. What do we mean when we say a screening test? What's the whole purpose of screening? And this is important because we have to understand why we do these tests and think of them kind of as a population intervention. We're really trying to benefit the population and reduce harm to a population when we're screening. So there's really three basic principles to a screening test. The first one is very important, is to diagnose disease early in people who have no symptoms. And the no symptoms is very important. If you have symptoms like a cough or chest pain or shortness of breath, you shouldn't be having any kind of screening test. You should be having a test whose purpose is to try and find the cause of those symptoms. So screening tests are in people who have no symptoms at all. The other aspect of a screening test is it aims to detect diseases that respond better to early versus late treatment. This is certainly true for cancer in general, and especially true for lung cancer, as I will explain soon. Lung cancer, the earlier you can detect it, much better the treatment options, cure rates, survival outcomes. And the third, which is really important, and which we'll come back to a number of times today, is when you're screening, you must ensure that the benefits of treating the small number of people who will ultimately be diagnosed with the disease outweigh the harms associated with screening the large number without the disease. I'll take lung cancer screening as an example. We know from all our screening trials that when you screen high-risk people, the rate of lung cancer in that group, the lung cancers that you will find, are about 2%. That means 98% of the people that you're screening will not have lung cancer. And it's very important that we don't harm that 98%, but get the benefit for those 2% who will have lung cancer. So that risk-benefit ratio is very important when we're screening. And that's not just for lung cancer screening, it's for any screening test. And one of the major groups that helps make these decisions here in the US is called the US Preventative Services Task Force. And they are the ones that review all the data and make recommendations on what is a good screening test and what maybe isn't such a good screening test. You all are probably very familiar with many screening tests. Many of you listening tonight or later on YouTube have had some of these. We have pap smears for cervical cancer. We have mammography for breast cancer, colonoscopy for colorectal cancer, prostate-specific antigen or PSA blood tests, plus or minus a rectal exam for prostate cancer. Those recommendations have changed of late, and not everyone is recommended to have prostate cancer screening. And now we have low-dose CT, computed tomography, or CAT scan, as we commonly call it, of a chest for lung cancer. And I say now because it's newer. It's the latest to be added to this list you have here. It is really since about 2012 when this screening test was recommended and approved. So it's the newest tool in our toolbox, pardon me. So why does it make sense to screen in lung cancer? The problem with lung cancer, the reason lung cancer is such a deadly cancer is that most lung cancers cause no symptoms until they have grown quite large or they've spread to other areas of the body, whether it be their lymph nodes in the middle of the chest or distant organs. Because of that, lung cancer is often diagnosed at a late stage, what we call advanced disease. And the problem is that treatment is far less effective and survival is far worse in advanced or late lung cancer. The goal with lung cancer is always to diagnose it early, where treatment outcomes are better, cure rates are much better, and consequently survival is better. So lung cancer is kind of a perfect disease for screening, because if we can shift diagnosis from late or advanced to early stage, we're likely to have way better survival and way better outcomes. And that is what we've seen now. We're starting to see those numbers improve now that we've started lung cancer screening, and that's encouraging. This picture on your right here is just a CT scanner. Many of you have probably had one. You kind of go through this donut, and I'll explain a little bit about what do I mean when I say low dose CAT scans. What does that mean, a low dose? So here are some radiation doses just to give you kind of some perspective or comparisons. When you get a standard CAT scan that your doctor orders because you have a symptom or maybe you had a trauma and they want to look at your chest, that standard CAT scan has 8 millisieverts. And millisieverts is a unit we use to measure radiation dosing, 8 millisieverts of radiation. A low-dose CT or a low-dose CAT scan is about 1 millisieverts. So it's 1/8 of the dose of a standard CAT scan. To give you some reference points, a chest x-ray, your very basic to view chest x-ray, is 0.1. So a low-dose CT is about 10 x-rays. which may seem like a lot, but it's far less than 80 X-rays, which is what a normal CT is. And again, to put that in perspective, 1 year living on Earth just from cosmic rays and environmental radiation, we're all exposed to about 3 millisieverts a year. So that low dose CT is about 6 months of living on Earth in terms of environmental radiation. If you live in Denver at altitude, you get about 12 millisieverts a year. So that puts it all in context. And so these low dose CTs really are low dose. And that's one of the things that is aimed at reducing that harm that I was talking about. We want that benefit of screening, but we want to minimize the harm. Just a little bit more about lung cancer. Again, this is turquoise takeover. This is a time where lung cancer is in the spotlight. That means a lot to me. Lung cancer is very common and remains the leading cause of cancer death. Sadly, it kills more people than the next 3 cancers combined. As you can see here in red is deaths from lung cancer, and that is more than colorectal, prostate, and breast combined. So it still is the #1 cancer killer, and all the efforts we're talking about today and next week with Dr. Fuster are aimed at reducing the death rates. The 5-year overall survival is 22%. So 22% of people with lung cancer are still alive at 5 years. That seems very low because it is. That is better. I will tell you that it used to be about 15%. So we are seeing some improvements. But our goal is to get that even better. And again, the main reason for why that's so low is because of the diagnosis occurring late when the disease is already advanced and much harder to treat and cure at that point. All our efforts at reducing lung cancer rates and improving survival, smoking cessation remains very important. There are new treatments for lung cancer that are very promising. You may have heard about targeted therapy, which tries to kill cancer cells without damaging normal cells. You may have heard about immunotherapy, which tries to boost the immune system and make it recognize and kill cancer cells. And lung cancer screening, as I mentioned, has likely resulted in an improvement in survival because of early detection. I just want to go over the data that led to lung cancer screening very quickly. It was a big trial. Over 50,000 subjects were involved in this trial. It happened in the late 2000s, 2007 through 9, and was published in 2011. And again, in 2012 is when most of the professional societies and the Preventive Services Task Force made the recommendation to implement this screening. What they did in the study was do this low-dose CAT scan I talked about versus chest x-rays once a year for 3 years in a high-risk population. So these were people that had significant smoking history, as you can see here, greater than 30 pack years. For those that don't know what that means, 30 pack years means 1 pack per day for 30 years or the equivalent of that. So it might be 2 packs a day for 15 years, or it might be half a pack a day for 60 years. But that's what we call pack years. What the study showed after those 3 scans is a 20% reduction in lung cancer mortality, which is incredible. That's a very good reduction. And one way to change that reduction in mortality to a number that we can all understand is something called the number needed to screen. The number needed to screen for low dose CT is 320. And what that means is you need to screen 320 people to save 1 lung cancer life, to prevent 1 lung cancer death. That may seem ineffective or not very good to you, but I'll tell you that that's actually very favorably comparable to other screening tests we do. That's on par or better than mammography. So that's actually a good number needed to screen when we're talking about cancer screening tests. So this sounds great, right? We can reduce lung cancer mortality by 20% when doing the screening. Is there a cost to this? And sadly there is, and this, I'm a visual person, so this is a picture that I like to show people when I'm talking about lung cancer screening. It's easier to think about things visually. And this data is from that trial I just showed you. And what this data shows is 1,000 people on the right of your screen here who are not screened, and 1,000 people on the left of your screen who are screened with an annual, once a year, low-dose CAT scan of the chest. And these 1,000 people who are not screened, 21 of them died from lung cancer in that study I was telling you about. On the left, and the people who were screened, it was 18 people who died from lung cancer. So that's a reduction of 3. There were 3 fewer lung cancer deaths, 3 lives saved per 1,000 in the screening group. What is the cost of that reduction? What is the harms? In this group that were screened, you can see that 365 out of those 1,000 had what we call a false positive test. That means that they had something pop up on their CAT scan. Generally, that will be a nodule, a little, you may have heard a spot or a shadow as other terms. That means an area of white on a CAT scan where it should be just black air and lung. And that nodule ended up not being lung cancer. So that was a false positive. Out of those 365, 25 of those people had an invasive procedure, a biopsy, a bronchoscopy for that false positive result. So they had an invasive procedure for something that was not lung cancer. Out of those 25, 3 of them had a major complication. I'll say right now, these were not fatal, but these were deemed major complications like bleeding or a collapsed lung. So that's the trade-off here. You're saving 3 lives per 1,000 with screening, but you have a significant false positive rate, and 3 people in those thousands had a complication of an invasive procedure that they really didn't need because they ended up not having lung cancer. So how do you balance that, this balance sheet? And I think there's no right answer to how you balance that. I think it really depends on you. It depends on your value system. It depends on your risk tolerance or risk aversion. And so these are the kind of discussions I have with patients in my clinic all the time. I show them this, and many of them say, I appreciate 3 less deaths in every 1,000 screenings. I might be one of those saves. I want to have lung cancer screening. Some people might say, I really don't want to be among the 30 to 40% who might have a false positive test. I'll have to have invasive testing. I might have complications. That doesn't sound like a good idea to me. What if I'm one of the 3 who has a complication from those false alarm invasive procedures? Other people say, I'd rather not know. Just leave me alone. So it is a personal decision. And that discussion between a doctor and someone who's interested is very important to talk about those pros and cons. But I don't want to minimize the benefit. I think a 20% reduction is very important, but I just want to put it in the context that it does come with some potential harm that you want to think about. Where should you get, if you're interested, where should you get a lung cancer screening test? I think it's important to have your lung cancer screening done at a location that has a comprehensive lung cancer screening program, and program is the key word here. What I tell people, what I mean by that is you don't want to go get your lung cancer screening test in a mobile CT scanner in the mall parking lot. As tempting as that might be, it's much better if you get it somewhere where you have all the elements of a high functioning program. These places will have a systematic way to identify people who meet criteria for screening, lots of educational materials, and the shared decision making I just shared with you, that kind of balance sheet, the pros and cons. It is recommended that a screening program have a dedicated nurse navigator or coordinator whose only job is to track everyone, communicate, make sure everyone's going through the program appropriately. Ideally, it's paired with a good smoking cessation program. We know that smoking cessation saves lives. Well, smoking cessation with lung cancer screening is a very good way to save a lot of lives. Put those together. There's very standardized radiology reporting, much like if you get a mammogram, you'll get a biorad score. When you get a low dose CT, you'll get a lung rad score. So you want to make sure your radiologists are reporting those correctly. That really helps to reduce the harm of potentially unnecessary invasive procedures down the road. You want to make sure you get your scan at a location that has all the downstream specialty services you might need. That might be pulmonary, cardiothoracic surgery, oncology, radiation oncology, pathology. Ideally, you want to have all of those together in a good system. And ideally, you want to have them meeting in something called a tumor board, where they all get together and review every new diagnosis of lung cancer together to come up with the best plan. I can tell you that we're lucky here in San Diego. There are many good programs that offer all of this. And then finally, you want a good tracking system and you want to monitor outcomes. So I can say as a UCSD and VA physician that we do offer all of these elements, but I'm not pretending that we're the only ones in town. There are lots of great programs in San Diego. We're fortunate to be here. These are the US Preventative Services Task Force guidelines. These were updated recently in 2021. So who should be screened? Who is eligible for lung cancer screening? Currently, the recommendation is adults aged 50 to 80 years old. This recently changed from 55 to 80 down to 50. So we're starting screening a little bit earlier. And patients who have a 20-pack year history. So again, a pack a day for 20 years or the equivalent. That used to be 30. So we moved that down from 30 to 20 recently. You need to be a current smoker, or if you quit smoking, it has to be within 15 years. If you quit more than 15 years ago, it's felt that your risk of lung cancer is low enough that you wouldn't benefit from lung cancer screening. That change, going from 55 to 50 and from 30-pack years to 20, might seem small, but it actually doubles the population of people eligible for lung cancer screening, doubles it. So it's an important change that was made, and hopefully many more people will benefit from lung cancer screening. You'll notice who's not included in this, and that's non-smokers. And I get asked all the time, what about people who don't smoke or have a very light smoking history, but maybe they have another risk factor? Maybe they have a family member a family member who had lung cancer. Currently, the recommendations are not to screen non-smokers. And I bring you back to that balance sheet I showed you. If you screen more and more people, if you screen everyone, what could happen is benefits will diminish, the number of lives saved will diminish, but the potential of people being harmed by false positives and the downstream of false positives would go up. Now, I recognize that there are people out there who are non-smokers who develop lung cancer. I see it all the time. I'm interested in lung cancer in women, and we know that non-smoking women get a specific kind of lung cancer called adenocarcinoma. It's a personal interest of mine, and I do want to see improvement in the future in trying to select people who will benefit from screening earlier on. And I'll talk a little bit about what the future might hold in that regard. This is just to kind of come back to that point I just made. What are the challenges when you're screening people in a mass screening program? I think we can all appreciate that risk exists on a spectrum, right? Risk is not black or white. There's plenty of grayscale in risk, and it kind of goes up on a spectrum. And the problem with our cutoffs, our age cutoffs, our 20-pack year smoking cutoff, our 15 years, if you quit within 15 years, those are very black and white. Those are very kind of arbitrary. And that's the problem with having black or white cutoffs when risk is actually exists on a spectrum. And I'll give you an example here of some of the shortcomings of our current criteria. We have these nice risk calculators that we use as pulmonologists, where you can put in a lot of information about a person, and try and predict for risk of developing lung cancer over the next 6 to 10 years, depending on the calculator. Here are some examples from using those calculators. Here's a 48-year-old African-American male, smoked 30 pack years, quit 3 years ago, has less than a high school education, has a history of bladder cancer, has chronic obstructive pulmonary disease, that's a form of lung disease, and has a family history of lung cancer. Boy, that sounds like someone who should be screened, right? Risk of lung cancer, when you plug all of that into our lung cancer risk calculators, is 3.1%. That's considered high risk. Anything above 0.9 to 1% of developing lung cancer over the next 6 to 10 years is considered high risk. Unfortunately, this person would not be eligible because of their age. They would have to wait till they're 50 years of age. Contrast that with a 52-year-old white male, also smoked 30 pack years, quit 10 years ago, high school education, no personal or family history of cancer. You plug that into the calculator, this person has a 0.5% risk of developing lung cancer. That's considered low, less than that 0.9 to 1. But this person would meet all criteria for screening: 52, 30 pack years, quit within 15 years. So there's definitely some problems with our very black and white screening criteria. And believe me, there's a lot of interest in fixing that problem moving forward. I do want to mention disparities, since I mentioned African American versus white. There are definitely disparities in lung cancer risk and access to lung cancer screening. In California, our data shows that the risk of lung cancer is higher in African Americans. They have an incidence of 54 new cases per year per 100,000 people compared to 48. We also know that if you're African American, you are less likely to be diagnosed at an earlier stage and less likely to have a curative surgery offered. Important disparities that we're very interested in addressing moving forward. How might we better select people who would benefit from screening, and how might we reduce harm after we've done a screen and found a nodule? That's where biomarkers, I really hope, are coming in the future. Biomarkers are essentially additional data that your doctor might be able to get, perhaps from a little brushing of your nose, collecting some nasal mucosa and doing some genetic testing on that, perhaps from exhaled breath, or perhaps from a blood test. And using these different tools, we may be able to better classify people. We might say your biomarker indicates that you're at higher risk of developing lung cancer. Therefore, we do recommend screening, even if you don't meet all of those other criteria. Similarly, it might say you're lower risk. The same applies to biomarkers that are being looked at for nodules. Let's say you have a scan and we find that you have a lung nodule. If we can get a biomarker that says this lung nodule has a low risk of being lung cancer based on your biomarker or your classifier, we feel much safer just following that nodule with serial CAT scans over time to make sure it doesn't grow or change. Whereas if your biomarker or classifier says, this is higher risk, then we might go straight for a biopsy or even cut it out. So these are things that are in development, in studies that are coming, that I think will really help us make better decisions. And I envision a day where we'll have biomarkers that we can add to the risk calculators I was showing you earlier to even better define who might benefit from lung cancer screening. And my pipe dream is that even that non-smoker who has a family history and maybe a couple other risk factors, who's very worried, biomarkers may help us decide who would benefit from screening. Coming back to a little bit, I mentioned briefly disparities in lung cancer screening. We know that all of these things really matter. Race, ethnicity, like I just mentioned, access to care is a big part of it. We know that that's related to socioeconomic status, insurance coverage. There are specific populations that seem to be at higher risk for lung cancer and poor outcomes in lung cancer, HIV positive being one of them. And there are many social factors that have been shown to play a role: education level, housing, where you live, rural versus urban, et cetera, et cetera. I bring this up because this is not a proud moment for me to share this data. In California, only 6.4% of those eligible for screening are actually screened. We're not worse than other states. Sadly, that's around the mean for the United States, but that is a tragically low number. As we're talking about potentially expanding the population of people we're screening, I mentioned those updated criteria. It saddens me to see that we're not even screening those that meet criteria. Less than 1 out of 10 people who meet criteria actually get a low dose CT. We don't really know why. Some of it might be access, utilization, getting the word out there amongst physicians, providers, nurse practitioners, that we need to be doing this, identifying those people who would benefit from screening. There are lots of factors and there's lots of things where we could definitely do better. I encourage all of you listening, if you're interested, to raise the issue with your physician. Say, hey, I heard a talk about lung cancer screening recently. Is that something I should be thinking about? What we need to do on our end is use some of the tools that we have. For example, the electronic health record. Maybe that's a great way to identify people who meet the criteria for screening and make sure that they are flagged so that at their next visit, the topic is raised with them. We can leverage a lot of the tools we have in information technology to do a better job. But we also need to do a better job of reaching out to those people who maybe don't have frequent access to healthcare, those rural populations, those lower education levels. So we have a lot of work to do here. I just want to end with, it's hard not to talk about COVID these days. So how has the COVID pandemic affected lung cancer screening and screening more generally? There's a lot of data coming out on this recently. A lot of this has made your nightly news headlines and your news magazines and web headlines, because it's pretty alarming. We now know that during the pandemic, cancer screening in general, this is not just lung cancer screening, went down by 50 to as high as 90%. Some of the data we're seeing out of some centers during the COVID pandemic. So major reduction in the number of screening tests done during the pandemic. Also a lot of challenges for those that were getting screened. Very hard to have good nodule follow-up in a health system that's already strained by COVID. Personnel resources heavily taxed by the pandemic. Less people who have time to be tracking people down, saying, hey, your next CAT scan's overdue, you need to come in and get your screening CAT scan. All of that was taxed by the pandemic. What does that mean? And this isn't just cancer screening. I think many of us who are here taking care of patients with asthma and patients with chronic diseases can probably attest to the fact that just the good checkups and good care of those chronic diseases was derailed by COVID. And so a lot of people are concerned that we will, or perhaps we already are seeing a surge, but not of COVID, but a surge of advanced chronic illness or advanced cancer that will come next. All that derailed care over the last 2 years, what will be the net result of that? I'm not saying that to scare anyone. I think my PSA is just, now's the time. If for the last 2 years you were worried to go get your screening test, now's the time. Health systems are restoring all of our services. We now know that it's perfectly safe to go to your doctor's clinic or your hospital to an appointment without risking getting COVID. All the safety measures are very effective, and it's very important to resume screening and resume your regular checkups, because we don't want to have our next pandemic be one of advanced cancer because we missed an opportunity to diagnose cancer early. So that's my public service announcement, is now's the time to get back to your screening tests, your preventative health checkups. A little plug for next week's Community Connections. So talked about lung cancer screening today. What happens if you have your low-dose CT and it's positive? The low-dose CT found a nodule. What happens next? people often have a lot of anxiety about that. I did discuss some of the potential harms related to procedures for those false positives, but there's a lot of really exciting news coming. And next week, Dr. Fuster is going to talk about updates in the early detection of lung cancer. This here is a picture of something called robotic bronchoscopy, which is a almost remote controlled bronchoscope that can navigate almost through a GPS-like system down to very small pulmonary nodules to get a biopsy of them. These updated technologies are really going to reduce those harms I was talking about on those balance sheets. We're talking about very well tolerated, very safe procedures that are capable of biopsying very small nodules in a non-invasive or far less invasive way. So that's another benefit. As these technologies come to bear, we're going to see those harms are going to go down, and we're going to see even more benefit from lung cancer screening. So that with biomarkers, I think, are really the future of lung cancer screening, and perhaps even improving the really good results we're seeing from screening in terms of reducing mortality from lung cancer. So with that, I think I'll end and welcome all my panel colleagues and take some questions.
Well, thank you very much, Dr. Montgrain. That was great. We are going to be joined by Dr. Mike Welsh, who is a longstanding volunteer for the Lung Association and a pediatric allergist, and Dr. Mark Fuster, who, as you know very well, is another specialist in lung cancer. We also have a special guest, Dr. El Hassa, who is a pediatrician from Orange County, who's joining us, and a longstanding volunteer for the Lung Association as well. And I think that's it for our panel today. But let me start off while everybody's getting situated. And I wanted to follow up on the very last thing you said, which was that there are some advances in both diagnosis and in treatment that have really substantially changed since the study that you quoted was performed. And just for people that aren't aware of this, back in the early 2000s, in the first decade of the millennium, the way to diagnose lung cancer was pretty much done with essentially what looked like a pair of needle nose pliers at the end of a bronchoscope. And you would sort of try to pinch, looking at a regular plain X-ray, you'd look to try to pinch the area that had the cancer, and you'd pull that back and you'd see what you have. It's a little bit more sophisticated than that, but not that much more sophisticated than that. And then for treatment, you pretty much had surgery, or you had some other pretty dismal options. And I'm wondering about now, where, as you said, the advances in diagnosis, which we're going to hear a lot about next week, but they're really a remarkable sea change in the ability to diagnose relatively small things very accurately, plus the combination of that and our advances in treatment. Have we really changed the risks and benefits of screening? Is screening much more attractive now than it was 15 years ago?
That's a great point, Dr. Morrison. I think we have. I don't know that we have the data to show that yet, and I think that data will be coming. We certainly have some data locally at our VA where we've shown screening to be incredibly safe. We even have a higher rate of lung cancer in our screened population. In the National Lung Screening Trial, it was about 2%, like I mentioned, and Dr. Fuster, correct me if I'm wrong, but it's more like 3 to 4%. So we have more benefit. We are detecting more lung cancer earlier, and it's been incredibly safe. We have not seen a lot of harm, and the reason for that, I think, in part, is because of these advanced technologies that you mentioned, but also having a good multidisciplinary tumor board where all the experts get together in a room together and review every single case, every single new nodule, so that the correct decisions are made. But it's a team effort, and our radiologists are super important in giving those lung rad scores and from there on out. But yeah, I agree with you, Dr. Morris. I think that balance sheet I was showing you, if that didn't look great to you, I would say it probably is much better today, because the harm of those false positives is going down consistently as we improve our diagnostic capabilities. And then when you if you are diagnosed with lung cancer, our treatment options are way better. Even our surgical modalities, if we're going to cut out your lung cancer, that has improved tremendously. Now it's done through a minimally invasive, what's called video assisted thoracoscopic surgery, often with a robot. Most of these are robotic now. So that minimizes the amount of time you're going to be recovering. Outcomes are really good. So I think as all these things improve, that balance sheet is going more and more in favor of screening. Yes.
And I just bring up to echo one of the points you made that's balanced, that you spoke about really well, is not just the technology that is sometimes safer. You get smaller nodules safely through the inside rather than poking a lung from the outside and getting a pneumothorax or a complication than someone that has, minimal lung reserve, but also just being in a tumor board where there's more data and more risk calculators used and more decisions about who could safely be irradiated without a biopsy, and where you feel with high probability it's lung cancer. Some of those decisions you never make on your own, we make in a tumor board, and that brings safety in itself. And 10 years ago, we might have had a lot more cases where we could have harmed people. And so using the data of time and risk calculators, we know we have a better feel for who's the high end that's really at high risk and goes to surgery, and the people in the middle that maybe we need a biopsy, and some people that you maybe don't biopsy if the risk is too high, and you treat empirically for lung cancer, and meaning without tissue. So all that's weighed in terms of better technology, but better decision making as a group too. And I think you put it really well there, Phil. I think that.
Well, that's what's encouraging. Thank you, Mark, for that. That's what's encouraging about our data here at the VA. This is a pretty high risk population for potential harm from biopsies. A lot of our veterans have emphysema or pulmonary fibrosis. And so it's very encouraging to see that lung cancer screening has been really safe in a population that you would think would be at higher risk for harm to the potential procedures downstream. And we haven't seen that. And I think that's because of the technologies Dr. Morris mentions, but also just what you're saying, Dr. Fuster, the multidisciplinary tumor board, getting everyone together on the same page, reviewing these cases every week, and coming up with really good plans.
I did want to take a second to, I noticed that Captain Alma Lowry, who I have finally now not stopped calling Dr. Lowry, and I will tell her by her real title is Captain Lowry, has joined us. Captain Lowry is from the San Diego Fire Department and is one of the first responders that's been helping us out long before people end up on our doorstep. So welcome back, Captain Lowry. I was wondering if you folks who have been involved in it could tell us a little bit more about what a tumor board is. I don't think a lot of the listeners would understand what that is. Could you set the stage? What happens at a tumor board?
Yeah, I'll let our clinical director of a tumor board, Dr. Fuster, answer that question.
Sure, yeah. So examples in the VA, but there are tumor boards everywhere. More than, I'd say it's between 10, 20 years ago, it's pretty well recognized that there's a lot more mistakes in trying to diagnose and treat cancer in general by yourself. So, sometimes, and that's really the message, multidisciplinary care leads to much better calculations for safety, higher accuracy. There's a lot of good literature on this from more than 10 years ago, 15 years ago, that having a multidisciplinary team in a room when we have a case for a patient that has potentially cancer or has cancer, it does a lot better and goes a lot further and is a lot safer. And we learn this through the types of discussions we have. A tumor board is a group of experts that come together that represent exactly what the word multidisciplinary is. So there's a radiologist, there's a radiation oncologist, there's a medical oncologist, there's a pathologist, there is, the pulmonologist who's presenting the case sometimes it's the oncologist presenting the case. And it's their own patient that feels much more comfortable bringing up to the whole group than thinking by yourself and whipping out textbooks and papers to think of, you're gonna make that decision. And you know how you learn that in a tumor board is so effective is when you do that yourself and you bring it up that way, they hit you over the head with something that you didn't even think about. And you're like, that should have been that other paper I looked up. And it makes all the difference in the care of that patient. So it's a wonderful place where very active discussion takes place. We love in a very healthy way to just sort of, repartee off each other's ideas and build and do the right thing for the patient. And it's amazing the difference thinking as a group than thinking by yourself. And those are also the very people that are going to be treating the patient down the line. So they're involved directly in the care. So it's I think that's the best way I could say it. And it's a model, it's a standard of care among all epithelial tumors, or most sarcomas too, and many tumors, median tumor boards, just unique boards for that.
Right.
I actually had a question, but if someone else
please.
Could I chime one in? It was great when I think you were mentioning, I think Dr. Montgrain was mentioning these kind of different aspects that make people not want to get screened. And it's really heartening how you brought up that really low percentage that most states in the United States, even the US, that's trying to screen and do a good job, that of those eligible for screening, we only need a small fraction. And the kind of factors that you brought up are really, really important. There's access, there's advertisement, maybe just getting the word out. There's forums. The ALA is a great forum to just get the word out. All these are positive. They're all good because they help you think about doing it when there is a mortality benefit. It just has to be good shared decision making. Reminders, these kind of things. And then I think there's always one, and this is where I want to get Dr. Montgrain's opinion. There's those, and then I always think of even if and it's like in your face and it's the right thing to do, the fear factor, that just this unknown of having a scan and I might find out something that I'm really worried about. That sort of last point you made about, I just don't want to know it's me kind of thing, one of those. Uh-huh. And I just bring it up because sometimes these new biotechnologies, you brought it up really well, Dr. Montgrain, the idea that, you might have a blood test that helps know that then you should do the scan or not. And maybe that stepwise thinking, I know it's going into some technologies about sort of making decisions early on and reducing the fear, but I just want to get your take on all these kind of factors versus fear and what you think our population mainly suffers from. Is it just a lack of advertising, or is it just not wanting to know what's happening to yourself and how we can make it better?
Yeah, well, it's a great question, and it's a challenge. And first of all, I want to acknowledge and thank the American Lung Association for all the work they do with their Saved by the Scan campaign on getting the word out. And a lot of it is getting the word out. When we're screening less than 10% of who we should be, I think some of that is on us as a professional society, as a medical society. We clearly haven't disseminated and implemented this evidence to the best we should be doing. I think the fear factor is always going to be part of it. And I do think we have to be respectful of certain cultural and risk tolerance and differences that an individual might have. But I agree with you that part of it is demystifying some of the fears. There's no question that your lung cancer is going to be far more curable the earlier we find it rather than finding it late. And that really should be the take-home message. I think the biomarkers we talked about could be really helpful in having those discussions. And also, these personalized risk calculators I find really useful because it's very personal to the person you're having the discussion with. If I can really put a number on what your risk is of developing lung cancer based on all the information I have about you as an individual, and perhaps add to that a biomarker, some nasal mucosa, exhaled breath, a blood test, and say, okay, based on everything we know, your personal risk of lung cancer over the next 6 years is X. I really think we should be doing lung cancer screening. That may help strengthen it. It becomes more personal rather than like, oh, here's this thing we can do to, and we know that if we do this 20% reduction in lung cancer mortality, that's not always very personal to an individual. And I think that's where medicine's going in general, right? The concept of personalized medicine, just making it very relevant to you as a person sitting across from your doctor in an office.
I do want to mention that the Saved by the Scan program that you just mentioned, there's a link to that in the chat box there.
So terrific.
Yeah.
Thank you.
Yeah, as you said, it's
great, terrific work, and I'm very grateful for it.
Dr. Montgrain, could you explain what you meant by when you said that some people are eligible for screening, and you had mentioned one person who might have a high risk who was not eligible, and then another person at a lower risk that was eligible. What exactly should people take home as what eligibility means? And does that mean if you order it, that like the radiologist is going to say, I'm not going to do it?
Yeah, that's a great question. And it is, Dr. Morris, very dependent on the specifics of the health system you're working on and your insurance, unfortunately. By eligible, I mean you meet the current criteria by the U.S. Preventative Services Task Force. So to recap those, what the U.S. Preventative Services Task Force is recommending is people who are aged 50 to 80, have a 20 pack year smoking history, so a pack per day for 20 years or equivalent, or if they quit within 15 years. So current smokers are quit within 15. That's what I mean by eligible. Those, if you meet those criteria, no radiologist will deny you a lung cancer screen. No, I shouldn't say no insurance company. I know that's still, certainly in California, I can say that no insurance company would deny it. I know that in some states, they are still fighting for coverage for lung cancer screening, believe it or not, despite the clear recommendation by all professional societies and our U.S. Preventive Services Task Force. I think where it gets more interesting is what about people who don't meet those eligibility criteria? Because I just showed you two examples where the person with a higher risk was not eligible and the person with the lower risk was eligible. And that's work we have to do as a medical profession to improve our screening criteria. Those eligibility criteria, in my opinion, they're too black and white. They're too, I don't want to use arbitrary, but we all know your lung cancer risk doesn't go from 0 when you're 49 to 10% when you're 50, right? That's not how it works. It's a spectrum, it's a gradient of risk, and we're not capturing that very well right now. That's why these risk calculators that Dr. Fuster and I use, and that's what I use to show you that example, along with hopefully biomarkers in the future, can help us do a better job. Unfortunately, we're stuck with those eligibility criteria for now, and that's what I mean. If you don't meet those criteria, it's possible your scan will be denied or not covered by insurance.
Hey, I have a question. You didn't mention, and by the way, I guess we should really say on May 4th, you should have ended your talk, may the lung screen be with you. So you didn't mention.
Well, thank you for doing it, Dr. Walsh.
Yeah,
it was perfectly delivered.
What about a repeat scan? So you got a negative scan, you're looking good, but you still have the risk factor hasn't really changed.
Yep.
What is the recommendation for a repeat scan?
Well, thank you. That I realize I didn't mention that, which is critical. To really see the benefit of lung cancer screening, you need to remain in the program until you no longer meet criteria. So you really should be having an annual, every year, low dose CT until you either age out, you hit 80 years, greater than 80 years, or it's been 15 years since you quit. But we do recommend that you keep having it every year. And that's why I said a good program will have a dedicated person, a nurse navigator, whose job it is to track those people down and say, hey, you're due, you're overdue. We really ought to be getting your annual scan now. If we do find a nodule, we may be getting them more frequently than every year. You might have one every 3 to 6 months for a little while to make sure that nodule isn't changing or growing. That's a very important way to track nodules that we do find. It's critical to the success of these programs. But thank you. The study I showed, they did it once a year for 3 years. But in real life, to see full benefit, we recommend that you keep getting it every year until you no longer meet criteria, until your risk has gone down enough that you no longer benefit, if that makes sense.
So even if one scan is clean, you figure by the next year, maybe something will come up that people should pay attention to.
And they do. We know from the studies that nodules pop up in between screens. And guess what? Those have a higher chance of being lung cancer.
Mm.
Yep.
Dr. Montgrain, mentioned other risks besides smoking, and we had just come from that fabulous talk last week about the dangerous effects of vaping. And I understand that vaping didn't really even exist when the lung cancer screening data that you showed was published, where the criteria were established for who should get screening. But do you think that should weigh into things, whether somebody's vaping instead of smoking?
That's a great question. And I currently don't have any evidence to base an opinion on or a recommendation. I think Dr. Crotty has shown us very nicely that there are many bad health effects of vaping. And we know early on, looking at some of the e-liquids and testing them, that they do contain a lot of the carcinogens that traditional cigarette smoke contains, albeit often at a lower level, but they contain them. You're still combusting something to create that vapor, right? And we know that that combustion process creates that vaporizing process creates carcinogens. So it could very well come into play in the future. I think data and science will have to guide us there. But I agree with you. It's quite possible that perhaps it won't just be pack years in the future. I don't know how we quantify vaping. I'd have to ask Dr. Claudia-Alexander how we might quantify that. It certainly won't be pack years, but it could be a risk factor we look at. Yeah.
There's so much heterogeneity in the inflammatory risks from all the subtypes and the vehicles and the flavors. It's really fascinating that, you know, even there's some lung cancer risk buried potentially in some of that, not only carcinogens, which, as you correctly point out, Dr. Montgrain, they do have things like formalin, formaldehyde. These things in trace quantities are just directly dangerous. But I fathom in like what in the world these kind of inflammatory effects can have in the lung, and the secondary effects of getting cancer. We just don't understand that well, but we have seen a lot of work on inflammation and cancer. And so
yes,
those are things we take to heart, and we're just very concerned about in vaping as well.
That's a very good point. Chronic inflammation creates an environment that promotes.
It's at risk, maybe. Yeah.
May promote cancer generation. Yep, that's a very good point.
Let me ask you a question about San Diego. We have so many healthcare delivery systems, you know, whether it be Scripps, Kaiser, UCSD, et cetera. And this kind of a screening program is, you know, lends itself to systems like what we have to implement these things. Are we doing a good job? Are these delivery systems we have in San Diego, are they doing a good job of at least attempting to get patients identified who then are put into to the screening program? And what kind of grade would you give San Diego in that regard, in these healthcare systems?
Yeah, that's a great question, Dr. Walsh. And I don't want to speak too much about other systems that I'm not a part of, but my impression is that many of our health systems in San Diego are doing a really good job of implementing these lung cancer screening programs. And I stress the word program. It's not just the CAT scan. The CAT scan is just a tiny little step of a good program. And so I do think we're fortunate. I mentioned that earlier. I do think we're fortunate in San Diego that we have good programs established at these groups that you just mentioned, Dr. Welsh. Clearly, we're still not reaching out to everyone we should be. You know, I don't have San Diego specific numbers, but it's hard for me to believe that if it's less than 10% for California, that we're doing that much better. So we have the programs, we have the downstream care, we have a quality in our health systems, but we're still not getting to everyone who should be scanned. And that's where we need to do a better job.
To follow up on that question, there are people who are getting healthcare from other practitioners that are not part of these giant healthcare systems. You know, they're not in the Scripps or Sharp or UCSD system. Is there something for them? What about the person that goes to the San Ysidro Family Health Clinic or something like that, who is eligible for screening? What would be your advice with them?
Yeah, I mean, they certainly can have the screening test done at their local site with a doctor that they trust. The caveat to that, though, is that all the downstream stuff I mentioned, you really want to reduce the harms if you do have a positive screening test. And so that multidisciplinary tumor board we talked about, you're probably not going to have that at a place like that. So if possible, I really recommend that that patients be referred to health systems that have a good lung cancer screening program. Again, like I said, in California, we're fortunate that this will be covered by all insurance. So it doesn't really matter where you get it. And I know that people develop a trust with their doctor, and that's very important. But perhaps after having that discussion and someone says, yeah, I think I do want to get lung cancer screening, it may be preferable to have it done at a health system that has all those elements of a high functioning, high quality program that I mentioned.
So maybe an easy way to migrate to it if you have that situation, like good fluidity between them would be nice.
Yeah. I mean, there's always that communication, that back and forth, making sure that the referring doctor stays in the loop. That's all very important. I don't want to minimize that. And of course, Dr. Morris, it can be done anywhere, but you do, to really minimize those harms, I think everything I mentioned in terms of a quality program is important.
Well, we're just about out of time, Dr. Montgrain, but thank you very much for that fabulous presentation. I certainly learned a lot, and I learned a lot from the panel discussion as well. Thank you to all of our panelists. A great big thank you to you, Dr. Montgrain. And please do join us next week when in the Community Connections series, we were going to follow up on this with Dr. Fuster doing sort of the sister talk to this, which is what happens next and what are the latest developments in lung cancer diagnosis. So thanks again, everybody, and we'll see you next Wednesday.
Okay.
Thanks, guys.
Bye.
You all. Thank you.
All right. Bye-bye.